So the topic of today's CGR is gestational trophoblastic diseases, God's first cancer and man's first cure. So this is labeled as God's first cancer because the first description of GTD was given by Hippocrates at around 400 BC. And there's an interesting drawing in one of his books wherein he's seen trying to deliver a female, and instead of a baby in his hands, he has grape-like vesicles. Also, there's a huge bowl lying by the side of this female which is filled with grape-like structures. The medical historians believe that this is the first ever description of a case of GTD. Hippocrates called it as dropsy of the uterus. Later on, almost 1000 years later, Smellie was the first who related the terms hydatid and mole with this kind of gestation. So hydatid basically means droplet of water, while mole in Latin means a false pregnancy. So this is a false pregnancy because instead of delivering a fetus, the woman's uterus is filled with grape-like vesicles. In 1827, Welpy and Bowen were the first one to recognize that these hydatid cysts were actually the cystic dilatation of the chorionic villi. What is a chorionic villi? It is the basic unit of the residue of pregnancy or placenta. In 1929, it was Eschim who detected that the patients who were suffering from GTD had excessive levels of HCG in their urine. Since then, HCG is a stand-alone tumor marker for diagnosis of GTD, which is not only helpful in diagnosis, but also in prognosticating the disease and also in follow-up. In 1958, it was Hertz and Lee who developed the use of Methotrexate as a chemotherapeutic drug in the treatment of GTD, and they achieved great success with the use of it because before the introduction of this drug, this disease was associated with a lot of maternal mortality. So a little background about gestational trophoblastic diseases. So what exactly is trophoblast? So trophoblastic cells are the first cells to differentiate from the fertilized ovum, and they eventually form the fetal share of the placenta. So in one word, these are the cells which are responsible to provide nutrition to the early embryo, and also later on these cells are going to invade the endometrial lining of the mother and are going to form the fetal share of the placenta. The placental trophoblasts are of three types: syncytial, cyto, and intermediate trophoblasts, and these are the origin of different types of GTD. So in GTD, what exactly is happening? It is the trophoblast which is proliferating, which also normally happens in the normal placenta, but this proliferation in GTD is dysfunctional, resulting in a highly invasive vascular and a metastatic tumor. So in one line, if I need to explain the pathology of GTD, these are maternal tumors which arise from fetal tissue that can have locally invasive or metastatic potential. So to classify, GTD is a broad spectrum of diseases which comprise of both benign and malignant counterparts. So the benign counterparts are complete and partial hydatiform moles. Other two are accidentally diagnosed and rare histological entities. So we'll be talking about only CHM and PHM. Among the malignant counterparts, this GTD is now termed as GTN, that is gestational trophoblastic neoplasia. And the four entities which comprise malignant GTD is invasive mole, choriocarcinoma, and placental site trophoblastic tumor, and epithelioid trophoblastic tumor. So 80% of the GTDs are normally benign, 20% of these are malignant. Among these malignant counterparts, invasive mole is the most common, and remaining three comprise only 5% of the whole spectrum. So coming on to the pathogenesis of CHM. So what exactly wrong is happening that this trophoblast is proliferating unregulated? So basically the problem is at the level of fertilization. So a sperm containing paternal chromosome is actually fertilizing an empty ovum. Empty ovum means that this ovum does not contain any maternal nuclear DNA. So when this fertilization occurs, it results into a product of conceptus which only contains paternal chromosome. This single chromosomal set is going to duplicate itself, and then a diploid product of conceptus is going to form, but it only contains maternal chromosome. Since there is no maternal genome available, so there is no fetus is going to form, and the trophoblast is going to proliferate unchecked in the absence of maternal genomic control. Similarly, in partial hydatiform mole, there is some fetal tissue forming. That is because two sperms are fertilizing an ovum which contains maternal nuclear DNA, and hence a triploid cell is formed which contains both sets of chromosomes. But again, since paternal chromosomes are excess in this cell, there is going to be excessive trophoblastic proliferation along with some fetal tissue forming. Coming to the epidemiology, so there's a marked difference in incidence across the globe, and this is secondary to change in genetic makeup, change in environmental and environmental exposure. So the incidence of H mole in Southeast Asia ranges from 1 to 2 per 1,000 pregnancies, and the incidence of GTD in India per se is 2 to 3 per 1,000 deliveries. Out of this, as I said, almost 85% are benign molar pregnancies and remaining are GTN. Gestational choriocarcinoma, as I said, is a very rare entity and it occurs in just 1 in 20,000 to 40,000 pregnancies and is more common in Asian belt as compared to Europe and North America. Coming on to the risk factors which basically try to explain that why this abnormal fertilization is occurring. So the most important factor is age. So in advanced stage, the quality of the ovum is poor, so probably there are more chances of having an empty egg, which is being fertilized by the sperm. So the risk is 5 to 10-fold increased. Also, if a woman has a history of GTD in the previous pregnancy, then the recurrence is 1%, and if there is a history of 2 molar pregnancies in the past, the risk is as high as 30%. People say that women with type A or AB are at slightly higher risk. However, we do not have enough data to support this observation. Incidence of GTN being high in low resource countries has made this observation that maybe a decrease in consumption of dietary keratin and animal fat is responsible. Also, there is genetic association. We have certain families wherein the woman presents with recurrent thyroidiform mole, and they say that it is because of the autosomal recessive disease associated with mutation in the NLRP7 gene. This gene basically leads to imprinting abnormalities and DNA methylation, which then leads to excess of paternal genome influence in the developing zygote. And hence there is excess of trophoblastic proliferation. So this is how they clinically present, the benign counterparts. They usually present with vaginal bleeding at around 6 to 16 weeks. There is excessive uterine size because the trophoblast is proliferating unchecked and unregulated. There could be prominent ovarian theca lutein cyst. Basically, the corpus luteum is being exposed to excess of HCG hormone, which acts onto the LH receptors of this corpus luteum and leads to development of large ovarian bilateral adnexal masses. Patient may also present with preeclampsia because we all know the root of preeclampsia is an abnormal placentation, and in GTD, the placenta itself is abnormal. So there are a lot of anti-angiogenic factors in the maternal circulation, and hence the patient may present with preeclampsia. Other symptoms of hyperemesis, hyperthyroidism, and rarely sequelae of trophoblastic embolization. So this is how a complete mole looks like on imaging. So you can see that uterus is filled with a heterogeneous mass with a lot of cystic spaces and no fetal structure is identified. On gross examination, it looks like grape-like vesicles. So these are dilated and hydropic chorionic villi. On histopathology, again, there is diffuse hydropic degeneration of the chorionic villi along with diffuse trophoblastic proliferation. And in the chorionic villi, one can appreciate that there are no embryonic blood vessels since there is no fetal tissue in complete hydatidform mole. In partial mole, fetus does develop because maternal genome is there. So this is the first picture is an image of an imaging done in early pregnancy. You can appreciate a gestational sac with a developing embryo. But in the deciduum, you can see multiple cystic spaces. And this is an abnormally sized gestational sac with an increased transverse diameter as compared to AP diameter. Again, if this pregnancy advances, maybe it will result in something which is shown in the second picture. There is a fetus which are normally anomalous. They may have hydrocephalus, they may have other anomalies like syndactyly. And sometimes these fetus die in utero at the time of diagnosis. And you can see a huge, large hydropic placenta by its side. Histopathologically, there is patchy hydropic degeneration of the villi and there is patchy trophoblastic proliferation. Since the trophoblastic proliferation is slightly regulated under the effect of maternal genome. Now, when a patient presents with molar pregnancy, before we plan the management, there is some preoperative workup that we do. The first and foremost is to do a quantitative HCG assay. As I said, HCG is a standalone tumor marker in this disease. So quantitative HCG assay is done before the initiation of treatment because this is going to be used in the follow-up of the disease. Besides that, few investigations are done to rule out for pre-anesthetic fitness and also to rule out liver and renal dysfunction since there is a placental abnormality there. TFTs are done because HCG, the alpha subunit of HCG simulates TSH and can lead to hyperthyroidism, so the TFT levels are done. Blood grouping and RH typing along with a chest X-ray. So why do we do chest X-ray? Because in GTD, the primary site of metastasis and the most common site of metastasis is lung. So once the patient presents to us for the first time, one may not be exactly sure that this is a benign disease and not already metastasized. So to rule out that, we do a chest X-ray to rule out any metastasis. If the chest X-ray is negative, then we do not need to do any further metastatic workup. So management, if it's a benign GTD, we have done the workup, we have done the imaging, we have correlated the clinical findings, and if it is a molar pregnancy, the choice of management is suction and evacuation. So we use a large Karman's cannula to evacuate the uterine cavity, and after the evacuation is done, we ensure that the uterine cavity is empty by doing a gentle curettage and removing any remnant trophoblastic tissue if it is there. This is sent for histopathological examination to confirm the histopathological type. There are rare complications associated with this procedure, which are uterine perforation, excessive bleeding, and trophoblastic embolization. However, in experienced hands, these are quite rare. Now, what is the role of doing hysterectomy in molar pregnancy? As I said, a conservative surgery in the form of suction evacuation is preferred and is first line in benign GTD, but sometimes we might have to resort to hysterectomy. And we prefer doing hysterectomy in patients who are already more than 40 years of age and who have already completed their family. And because by doing hysterectomy, we have ensured that there is complete evacuation of the disease. And also there is data to support that hysterectomy may reduce the risk of post-molar malignant sequelae. But however, it does not nullify it to zero. There is still 3 to 5% chances that in spite of doing hysterectomy, these may progress to malignant GTN. So to rule out that or to diagnose that at an early stage, a post-molar surveillance is mandatory even if a hysterectomy has been done. So this is how a post-molar follow-up is done. This is based on NCCN guidelines that we follow. So after evacuating a molar pregnancy, say complete or partial, these women are called back for serial beta HCG assessment every week. And once we document 3 negative values of beta HCG, then maybe they can be called every 3 months for 6 months post-evacuation. But during this follow-up, 15 to 20% of complete moles and around 1 to 5% of partial moles are going to become GTN. And how do we diagnose GTN in the follow-up? That I'm going to tell you in the subsequent slides. So what are the risk factors to predict malignant transformation? So at the time of evacuation, we look at certain factors to see whether this woman is more likely to go into malignant transformation. So if a uterine size is much larger than the estimated gestational age, if there are large thecal uterine cysts present, if at the time of presentation beta HCG levels are more than 1 lakh, if there is a history of previous molar pregnancy, or if at the time of follow-up, HCG does not normalize within 8 weeks of follow-up, then these are the patients wherein we suspect that probably a malignant transformation is likely to occur. So, but what do we do about them, even if we think that there are high risks of this benign entity turning malignant? Despite that, we do not start any kind of prophylactic chemotherapy because we have evidence which supports that if you start, first of all, it does not nullify the risk to zero. And secondly, one may actually increase drug resistance, one may actually delay diagnosis and treatment of GTN, and may expose women to toxic side effects. So we do not start any prophylactic chemotherapy, even if at the time of molar evacuation, we think that she's a high-risk patient who will going to develop malignant sequelae. But there was a recent RCT which was published by our Indian colleagues, and they said that if high-risk factors are there at the time of molar evacuation, one can just give a single shot of 100 milligrams of methotrexate, and this definitely reduces the chances of malignant sequelae. Now coming on to how do we diagnose GTN at the time in the follow-up. So as I said, we follow up these patients with weekly serial beta HCG levels, and at the time of follow-up, if we find that there are 3 beta HCG levels which are increasing at least 10% of the previous value, or if there are 4 beta HCG levels which are within 10% range of each other, then, or once we have sent the tissue for histopathological examination, the report comes out to be choreo or any malignant type of GTD, then the diagnosis of GTN is made. There are certain other criteria also, but however, these criteria are not supported by FIGO, but these criteria we may use in patients who have atypical presentations or who have lost to follow-up and then just have come back some few days after evacuation. So if even after 4 weeks of evacuation, the beta HCG levels are more than 20,000, or even after 6 months of evacuation, there is some beta HCG level present in the maternal blood, These are the two criteria which may help in diagnosis of GTN in some atypical presentations. Now coming to GTN, so as I said, there are four types of GTN: invasive mole, PSTT, ETT, and choriocarcinoma. So invasive, and before that, I want to emphasize on the fact that GTN may follow any kind of gestation. So mostly it is molar pregnancy. In the follow-up, the malignant sequelae develop, but sometimes GTN may present with following a miscarriage or following term pregnancies also. So the invasive mole is the entity which usually follows molar pregnancy, and there is then in invasive mole, the invasion is in the myometrium. So there's a vascular tumor in the endometrial cavity which invades into the myometrium, but does have a potential to metastasize. PSTT and ETT, they usually follow a term pregnancy. They present long after a pregnancy is over as a well-defined or irregular tumor in the myometrium, but it is very, very important to have a diagnosis beforehand because these tumors are chemoresistant. Just on clinical background and beta HCG levels, we do not start chemotherapy if we suspect PSTT and ETT. And the most important suspicion point is that they follow term pregnancies, usually follow term pregnancies, instead of molar pregnancies or abortions. Choriocarcinoma is a highly aggressive tumor. It is so aggressive that trophoblast proliferates and there is no differentiation even into chorionic villi. So in histopathology, there are no chorionic villi that one can appreciate. And at the time of presentation, these are metastatic. So the women may present with lung metastasis, vaginal metastasis, metastasis. So as I said, the patient may present with irregular vaginal bleeding following a conception which could be a miscarriage, molar, an ectopic, or a term pregnancy. They may present with hemoperitoneum, especially patients with invasive mole. The invasion occurs so deep that it may lead to uterine rupture and hemorrhage. So these patients lie in our ER almost in shock. So patient may present with hyperemesis, patient may present with symptoms associated with metastasis. So if there is lung metastasis, patient will present with cough, shortness of breath, may present with convulsions or dizziness in cases of brain mets, and may present with jaundice in case of liver mets. So sometimes these patients are lying in our medical wards and then are referred because probably their UPT came out to be positive, or in the ultrasound there is a doubtful pregnancy. So once in the follow-up or at the time of presentation we suspect GTN, besides the routine investigation that we do for any other molar pregnancy, the extra investigations are done only when we suspect metastasis. So basically when we do a chest X-ray, and also if it comes out to be positive, then a whole metastatic workup including CT of the abdomen, pelvis, chest, and MRI brain are indicated. Also, we do an ultrasound with Doppler because we need to rule out absence of a new pregnancy, a normal pregnancy, and also if it is not there, we need to find out if there is a tumor inside the uterus, which could be an invasive mole or choriocarcinoma or PSTT. This is how lung metastasis, as I said, lungs are the primary and the most common site of metastasis in GTN. They may present as a single solitary lesion in the chest, or they may present with an embolic pattern. So this is how the anatomical staging is done. However, stage does not make much difference in the treatment, but we must know that stage 1 is when the disease is confined to the uterus. Stage 2 is when it spreads beyond the uterus but remains in the pelvis. So if the patient has vaginal mets, which present as bluish nodules in the vagina, highly vascular bluish nodules in the vagina, it is stage 2. Stage 3 is lung metastasis, and any other distant metastasis to liver, brain is stage 4. But more important in the management is WHO FIGO scoring. So there are a few criteria that we include to find out the risk score of a patient, and based on this risk scoring, we manage the patient as in single agent chemotherapy or multi-agent chemotherapy. So if the patient is more than 40 years of age, she has a slightly higher risk score as compared to women with less than 40. Also, if a woman has developed this GTN following a term pregnancy, again the risk score is high. If the interval between the end of the last conception and diagnosis of GTN is more, again the risk is increased. Also, the serum HCG levels at the time of presentation, if they are increased, the risk increases. Similarly, as the number of mets increase, the site of mets is liver or brain, again the risk score is going to increase. And also, if the patient has had previous failed chemotherapy, the risk is increased. So after calculating the risk, if the low risk females are those who have risk score of less than 7, High risk are between 7 and 12, and anything more than 12 are called as ultra high risk GTN. Coming on to the treatment principles, so treatment of GTN is mainly, the first line recommended treatment is chemotherapy based. So it is essential to the treatment of GTN as a key factor in improved cure rate. So we have achieved almost 100% cure rates with chemotherapy for non-metastatic GTN. And also the regime is going to depend upon whether the patient is low risk, high risk or ultra high risk. There are other modalities defined, but all these are not alternative modalities. These are just adjunct to chemotherapy. So one might have to add second DNC or hysterectomy or myometrial dissection if the patient is willing to preserve her uterus. And sometimes in resistant GTNs, we might have to excise some metastatic lesions also. The upcoming is immunotherapy, which is again recommended only in resistant ultra high risk GTN. Now, when this low risk GTN is confined to the uterus, NCCN says that the clinician has three options to manage. First is obviously using a single agent chemotherapy, but these are the patients wherein one can also do a hysterectomy. So the hysterectomy along with bilateral salpingectomy, ovaries are almost always preserved. So one does a hysterectomy if the patient is more than 40 years of age, has already completed her family and wants to get her uterus removed. Only then hysterectomy is the option to manage uterine confined low risk GTN. Sometimes if the WHO score is very low, say less than 4, then one can even simply do a DNC, remove that tumor inside the uterus and then keep the patient on follow-up without giving any further chemotherapy. But for all other cases, and even the first line NCCN recommends that single agent chemotherapy is the treatment of choice in all the low risk GTN diseases. So when I say single agent chemotherapy, there are two agents defined. First is methotrexate and second is actinomycin. So this regime is repeated every 2 weeks, and before initiating a fresh cycle, HCG levels are assessed to see the response to the previous chemotherapy cycle. So among methotrexate and actinomycin, there are various regimes defined, but the most regime which we are experienced with is said to be the most effective is the 8-day methotrexate folinic acid regime, wherein methotrexate is given on 1357, 1 milligram per kg, and alternatively folinic acid rescue is given in the dose of 5 milligrams IV or IM or 15 milligrams per orally. Now this regime, 8-day regime, is repeated every 14 days. That is, the lady comes back on the 15th day, get her beta HCG values evaluated a day prior, and then a repeat cycle is initiated until we get beta HCG levels to be negative. So the primary remission rate with this 8-day methotrexate folinic acid regime is said to be almost 93% in low risk GTN. Now, as I said, two agents are defined, methotrexate and actinomycin, but which one is better? So we have a meta-analysis on this, and they say that although the cure rates of actinomycin are slightly better, but since the methotrexate has less toxicities, it is the preferred single agent chemotherapy in all patients with low risk GTN. So once the beta HCG levels normalize, say after 3 to 4 cycles of methotrexate folinic acid regime, we give additionally 2 to 3 courses as maintenance chemotherapy in order to decrease the chances of relapse or recurrence. And then once that is done, once patient has received both maintenance chemotherapy as well as initial chemotherapy, we call them every monthly with beta HCG levels for at least a year in low risk GTN. In high risk, the follow-up is a little longer. However, the pregnancy is strictly avoided during this follow-up because if a patient becomes newly pregnant and then beta HCG levels are going to rise and then the follow-up would become difficult. Sometimes a few of the patients, say 7 to 8% of them, are going to be resistant to the single agent chemotherapy. And who are these patients? These are the patients who present with large tumor size at the time of presentation. They already have some metastasis in the lungs, or they have very high pre-treatment beta HCG levels. So these are the ones wherein we anticipate that they might be resistant to single agent chemotherapy. So when this happens, when they become resistant, we see whether they responded initially to methotrexate or not. Suppose they responded initially to methotrexate and HCG levels at the time of becoming resistant, HCG is less than 1000. Then we can shift to some alternative but single agent chemotherapy, which is actinomycin. And we might also consider doing a hysterectomy if there's a large tumor sitting inside the uterus or the patient presents with excessive bleeding. Having done that, the follow-up is almost the same. That is, every 2 weeks before we initiate a new cycle, we look at the response by measuring the beta-HCG levels. And if still the beta-HCG levels plateau or rise, then maybe we need to shift to multi-agent chemotherapy. So even in methotrexate resistant GTN, the cure rates with dactinomycin are as high as 75%. So suppose sometimes it so happens that you initiate single agent methotrexate in low risk GTN, but from the initiation of therapy itself, these are poor responders. So in those patients, or HCG levels remain more than 1000 despite initial response. In these patients, we do not start an alternative single agent, rather we shift to multi-agent therapy, which is IMACO. And cure rates with this multi-agent chemotherapies are almost 100%, even in relapsed and resistant low-risk GTN. Now coming to high-risk GTN, wherein the FIGO WHO score is more than equal to 7. These are the patients who are straight away started on multi-agent chemotherapy. And these are the patients which we refer to our madam colleagues to start the multi-agent chemotherapy. Suppose these patients have brain metastasis, then they say that the dose of methotrexate in this regime needs to be increased as against any other site of metastasis. Also, if the disease is ultra high risk, say the score is more than 12, then straight away this 5-drug chemotherapy is not started. Rather, we start an induction chemotherapy. Because straight away if the patient is this patient with ultra high risk disease has a lot of tumor load, lot of vascular metastasis distributed throughout the body. So we start with 5-drug regime, then these may land into hemorrhagic crisis. To prevent that, these patients are initially started on cisplatin-based induction chemotherapy for 1 to 3 cycles, and then we look at the response, and then a full dose 5-drug regime is started. Again, the follow-up is same, that is every 2 weeks the response assessment is done and a new cycle is started. So the IMACO regime basically contains etoposide, actinomycin and methotrexate, which are given on day 1. On day 2, etoposide and actinomycin are repeated, and on day 8, cyclophosphamide and vincristine are administered. This cycle is again repeated on day 15. The complete response rates in high-risk disease with this multi-agent chemotherapy is as high as 78%, and the long-term survival is around 85 to 95%. Sometimes in resistant cases who do not respond to IMACO, a few other salvage therapies are recommended by NCCN, and these are TPTE, VIP, BEP, and ICE. Also, there is a upcoming role of immunotherapy, which contains immune checkpoint inhibitors, which act against PD-L1 and PD-1 receptors on these trophoblastic cells and expose these trophoblastic cells to maternal immunity. So maternal immunity will act as an anti-neoplastic agent. Now coming on to treatment of PSTT and ETT, as I said, these are chemo-resistant tumors. So instead of chemotherapy, we straight away do hysterectomy and salpingectomy along with pelvic lymph node biopsy, because lymph node metastasis is present in 15% of PSTT and ETTs. Also, following hysterectomy, we look for certain high-risk factors like deep invasion of the tumor, excess of necrosis, high mitotic count, and then we also consider giving them systemic chemotherapy even after hysterectomy. But if PSTT and ETT already present with a metastatic disease, then straight away along with hysterectomy, chemotherapy regimes are started, which are etoposide, methotrexate, and platinum-based. Now coming on to pregnancy after gestational trophoblastic disease. So once the patient is treated for benign or malignant GTN, later on if she becomes pregnant, the pregnancy outcomes are quite good. But one needs to do an early ultrasound scan to rule out recurrence, first of all. And second of all, once the patient is delivered, it is important that the placenta is sent for histopathological examination. And after 6 to 8 weeks post-delivery, the HCG levels need to be documented that they have returned to normal. And hence the rare occurrence of choriocarcinoma is ruled out. Now, as I said, contraception is very, very important at the time of follow-up. So, because a few of these females are going to conceive unscheduled during the monitoring period, and then the follow-up becomes quite difficult. So, the preferred modality are hormonal contraceptives. And besides that, even IUD, they say there is no evidence of any detrimental side effects, but IUDs are usually avoided. So the primary, the most preferred contraceptive method is oral contraceptive pills. Now coming on to our experience over the last 5 years, So we have had total of 38 cases. We might be missing on a few cases in the COVID, who were managed in the COVID pandemic on OPD basis. So a total of 38 patients we have full data. So there were 9 complete herediform moles and 9 partial moles. So as we know, the incidence of complete mole is a little higher than partial moles. But in our data, we have encountered equal incidence. This could be because partial mole present with a fetus inside. So these are difficult to evacuate. So these cases are referred more to us. So complete and partial mole each had 9 cases. We had 8 cases of persistent GTD. Among them, 2 were invasive moles. When I say 2 were invasive moles, that means on imaging there was a heterogeneous tumor which was invading into the myometrium. In the remaining 6 cases, we could not appreciate an obvious tumor in the uterine cavity, but the beta hCG levels were rising. So it was mostly a clinical diagnosis of persistent GTD. 10 of the patients had choriocarcinoma and all of them were referred to us from outside centers. We had 2 placental site trophoblastic tumor and both of them were histopathologically diagnosed. We have had no case of ETT. So all the women with partial and complete mole were treated by suction evacuation and none of them developed GTN in the follow-up period of 6 months. Now coming on to these 20 cases of GTN that we encountered, 8 were, as I said, were persistent GTT or invasive moles, 10 were choriocarcinoma and 2 were PSTT. So among the 8 cases of persistent GTD, 2 were invasive moles because the antecedent pregnancy was herediform mole and 6 cases were following abortions. The diagnosis was made on HCG and imaging and all of them were stage 1, that is they were confined to the uterus. 7 cases were low risk and 1 was high risk invasive mole. Choriocarcinoma, 3 cases followed herediform mole, 5 cases followed abortion and there were 2 cases which followed term pregnancies. Again the diagnoses were HCG, assay and imaging based and all of them presented with lung metastasis, with 2 of them presenting with vaginal mets also. So the 4 cases of chorio were low risk, 5 were high risk and 1 was ultra high risk. In PSTT, as I said, all of them present following term pregnancy, so both of them presented with abnormal uterine bleeding following term pregnancy and there was some not well defined tumor inside the uterus. A biopsy was done and it came out to be PSTT. Both of them were low risk. Coming on to the management, the 4 cases, the low risk cases were managed by single agent chemotherapy, that is Methotrexate, which also we prefer to use. One of the patients was managed with actinomycin D. The one with high risk was managed with Imaco and 2 of the cases we had to do hysterectomy because these were elderly females who presented with GTN. Low risk uterus confined GTN. Among choriocarcinoma cases, the low-risk patients were treated with methotrexate. The high-risk one was treated with Imaco. There was one patient who was ultra-high risk, who was first started on 5 cycles of doxorubicin, and then a full 5-drug regime was started. Among the PSTT patients, both patients were advised hysterectomy, but one of them was lost to follow-up, and one of them was receiving some platinum-based single-agent chemotherapy at some outside center on follow-up. We have had some interesting cases also. So we did in 2 patients, we did salpingectomy thinking that it's an ectopic pregnancy. However, on histopathology, they came out to be partial molar pregnancy. So in tubal molar, there are only 133 cases reported till date. And we have 2 cases of AV malformation following GTN. One of them was managed here with uterine artery embolization in our IR department. There was one patient who was referred to us as GTN and who had undergone 3 times DNC was done, saying RPOC. Even the histopathological review here at AIIMS was also RPOC, but there was a vascular tumor inside the uterine cavity. So this was managed hysteroscopically. The tumor was taken out and it was sent for histopathological examination. However, that also came out to be RPOC and not molar pregnancy. We had 1 case of molar pregnancy in a postmenopausal female. And in this, this was managed with hysterectomy. There was one patient, which the ultra high risk one, she actually presented with obstructive jaundice and she was initially admitted under medicine side. And later on workup, she was found to have metastasis in the lungs and even there was a vaginal mets. On ultrasound, there was this also we published. So on ultrasound, there was a heterogeneous vascular tumor inside the uterus and our beta hCG levels were 3.6 lakh. Again, this was the patient who had altered liver function. However, though no liver mets were there, She actually had obstructive cholestasis, and this patient was initially started on doxorubicin since she had altered liver function. 5 cycles of doxorubicin after she received, the liver function became normal. However, there was not much change in beta-HCG. So she was then started on a multi-agent chemotherapy, which was Imaco. She received 6 cycles, responded to it, and then 2 cycles of maintenance multi-agent chemotherapy were also administered, and patient is disease-free till date. So this is my last slide. So just a few summary messages. So in the diagnosis of GTN, one does not always need a histopathological diagnosis. Rather, we avoid doing a biopsy because these are highly invasive, highly vascular tumors. So diagnosis is mainly clinical and image-based and beta-HCG assay-based. Chemotherapy has markedly improved the prognosis in GTN. Prophylactic chemotherapy following molar pregnancy evacuation has a limited role. Low-risk GTN are usually treated with single-agent chemotherapy, and the preferred agent is Methotrexate. High-risk GTN are treated with multi-agent chemotherapy, preferably Imaco. Then beta-HCG follow-up is mandatory unless one does at least documents at least 3 negative beta-HCG levels. We do not beta-HCG levels, then after that only the patient is left for monthly follow-up. So role of surgery, so it is limited to PSTT, and contraception, OC pills I have already mentioned. Subsequent pregnancies, the outcomes are quite good, and fertility preservation is a rule in GTN as against exception. So because this is a tumor of reproductive age group. So this is all from my side. Before I end, I would like to acknowledge the faculty and residents, especially Dr. Dinesh and Dr. Shruti, who helped me compile the data. Department of Radiodiagnosis and Intervention Radiology, who help us diagnose metastatic disease. Department of Pathology and Lab Medicine, who help us diagnose some atypical cases. And also Department of Medical Oncology, wherein we send our patients for chemotherapy or for high risk and ultra high risk GTN. Thank you. I guess there are no questions. Thank you so much.